So the KEYNOTE-361 study, it's a randomized phase 3 study. It's 1,000 patients, frontline metastatic urothelial cancer. The study overall was negative. It compared pembrolizumab with chemotherapy with a combination of pembrolizumab and chemotherapy. For all intents and purposes today, I'm just going to talk about the pembrolizumab arm and the chemotherapy arm. And the reason why that's the case is because we performed ctDNA analysis on those two arms. We did it in about 150 patients in those two arms. We looked at baseline and we looked after 3 weeks of therapy, so a really short time interval, cycle 1, beginning of cycle 2, essentially. We then went on to look at how prognostic these ctDNA levels were. And then finally, we went on to look at the dynamic changes to see how significant they were. The first striking finding was 90% of patients were ctDNA positive. That, I think, was higher than we expected. We've never really looked at ctDNA in detail in advanced urothelial cancer before. The method we were using was the Guardant-Omni method, and we actually used a personalized, informed type approach. And there are different approaches, and using different approaches might get different percentage positivity of ctDNA. The second striking finding was at baseline, when we looked at the correlation between outcome and ctDNA levels at baseline. Those patients who had a higher baseline level compared to a lower level with pembrolizumab, the patients with a lower level did better than the higher level. And that wasn't the case with chemotherapy. So there were some discriminatory early findings between outcomes between pembrolizumab and chemotherapy with ctDNA. And this made us move forward and look at those dynamic changes. We looked at dynamic changes, as I said previously, between baseline and 3 weeks after starting chemotherapy or immune therapy. And what we showed with chemotherapy, the vast majority of patients got a reduction and 41% of patients got ctDNA clearance. Where with immune therapy, probably only about half the patients or 3/4 got a reduction, and the ctDNA clearance rate was only 11%. We then went on to look at the correlation between radiological response and ctDNA reduction. And what we showed is those patients that had a deep radiological response with pembrolizumab also had deep reductions in ctDNA clearance. However, with chemotherapy, it was a much more grey picture. There were lots of patients, even some patients with progression of disease, radiologically, that got reductions in ctDNA level. The next piece of our work tried to correlate these dynamic changes with outcome. And what we showed was is both with chemotherapy and with immune therapy, reductions in ctDNA were associated with better outcome, as you might expect. But those trends, particularly from a survival perspective, were much more marked with pembrolizumab. And what we showed is those patients that had large reductions in ctDNA with pembrolizumab did really well, where with chemotherapy, it was less black and white. We finally went on to link the ctDNA reduction with the pembrolizumab arm with immune biology, tumor mutational burden, and PD-L1. And we showed that of the 4 groups, high PD-L1, high TMB, those patients that had high TMB and high PD-L1, they had the deepest reduction in ctDNA with pembrolizumab, which is linking the immune biology with the ctDNA, which we thought was really exciting. So in summary, we don't know much, or haven't until now known very much, about ctDNA in advanced urothelial cancer. And what we showed is the vast majority, 90% of patients are positive. We showed baseline levels are prognostic. We showed dynamic changes occur in actually the majority of patients, particularly with chemotherapy, seeing these deep reductions. But it was the immune therapy, the pembrolizumab, where we linked outcome with these dynamic reductions in therapy. Where do we go from here? I think we've opened a new chapter. I think that new chapter has shown us that different settings, metastatic versus adjuvant settings, different percentage of patients who are ctDNA positive, but also different therapies are associated with different dynamic changes, which means that we're going to have to think much more carefully about how we use this tool in the future. It looks like this tool might be more useful for immune therapy in terms of predicting outcome than chemotherapy, for example. There are some limitations, as I said before. There are multiple different methods we could have used, and we use one specific method, number one. Number two is we only looked at one time point. And of course, although the analysis was done within the context of a randomized trial, it was exploratory in nature.